Now we will read about lung abscess. Lung abscess is a localized necrotic lesion of the lung parenchyma containing purulent material that collapses and forms a cavity. It is generally caused by aspiration of anaerobic bacteria. By definition, the chest X-ray will demonstrate a cavity of at least 2 cm. Patients who have impaired cough reflexes and cannot close the glottis or those with swallowing difficulties are at risk for aspirating foreign material and developing a lung abscess. Other at-risk patients include those with central nervous system disorders, that is seizure and stroke, drug addiction, alcoholism, esophageal disease or compromised immune function, those without teeth, as well as patients receiving nasogastric tube feedings and those with an altered state of consciousness from anesthesia. Pathophysiology. Most lung abscess are a complication of bacterial pneumonia or are caused by aspiration of oral anaerobes into the lung. Abscesses also may occur secondary to mechanical or functional obstruction of the bronchi by a tumor, foreign body or bronchial stenosis or from necrotizing pneumonias, TB, pulmonary embolism or chest trauma. Most abscesses are found in areas of the lung that may be affected by aspiration. The site of the lung abscess is related to gravity and is determined by the patient's position. For patients who are confined to bed, the posterior segment of the upper lobe and the superior segment of the lower lobe are the most common areas in which lung abscess occurs. However, atypical presentations may occur depending on the position of the patient when the aspiration occurred. Initially, the cavity in the lung may or may not extend directly into the bronchus. Eventually, the abscess becomes surrounded or encapsulated by a wall of fibrous tissue. The necrotic process may extend until it reaches the lumen of the bronchus or the pleural space and establishes communication with the respiratory tract, the pleural cavity or both. If the bronchus is involved, the purulent contents are expectorated continuously in the form of sputum. If the pleura is involved, an empyema results. A communication or connection between the bronchus and pleura is known as bronchopleural fistula. The organisms frequently associated with lung abscess are Staph aureus and Klebsiella and other gram-negative species. Anaerobic organisms, however, may also be present. The organism varies depending on the underlying predisposing factors. Clinical manifestations. The clinical manifestation of a lung abscess may vary from a mild productive cough to acute illness. Most patients have a fever and a productive cough with moderate to copious amounts of foul-smelling, often bloody sputum. Leukocytosis may be present. Pleurisy or dull chest pain, dyspnea, weakness, anorexia and weight loss are common. Fever and cough may develop insidiously and may have been present for several weeks before diagnosis. Assessment and diagnostic findings. Physical examination of the chest may reveal dullness on percussion and decreased or absent breath sounds with an intermittent pleural friction rub, grating or rubbing sound on auscultation. Crackles may be present. Confirmation of the diagnosis is made by the chest X-ray, sputum culture and in some cases fiber optic bronchoscopy. The chest X-ray reveals an infiltrate with an air fluid level. A computer tomography scan of the chest may be required to provide more detailed pictures of different cross-sectional areas of the lung. Prevention. The following measures will reduce the risk of lung abscess. One is appropriate antibiotic therapy before any dental procedures in patients who must have teeth extracted while their gums and teeth are infected. Second one, adequate dental and oral hygiene because anaerobic bacteria play a role in the pathogenesis of the lung abscess. Third one, appropriate antimicrobial therapy for patients with pneumonia. Medical management. The findings of the history, physical examination, chest x-ray and sputum culture indicate the type of organism and the treatment required. Adequate drainage of the lung abscess may be achieved through postural drainage and chest physiotherapy. The patient should be assessed for an adequate cough. Few patients need a percutaneous chest catheter placed for a long-term drainage of the abscess. A diet high in protein and calories is necessary because chronic infection is associated with the catabolic state necessitating increased intake of calories and protein to facilitate healing. Surgical intervention is rare, but pulmonary resection, lobectomy, is performed when there is massive hemoptysis, coughing of blood, or little or no response to medical management. Pharmacological therapy. Intravenous antimicrobial therapy depends on the results of the sputum culture and sensitivity, and is administered for an extended period. Penicillin G or clindamycin is the medication of choice, followed by penicillin with metronidazole. Large intravenous doses are generally required because of antibiotic must penetrate the necrotic tissue and the fluid in the abscess. The intravenous doses is continued until there is evidence of symptom improvement. Long-term therapy with oral antibiotics replaces intravenous therapy after the patient shows signs of improvement, usually 3 to 5 days. Improvement is demonstrated by normal temperature, decreased white blood cell count, and improvement on the chest x-ray. Oral administration of antibiotic therapy is continued for an additional 4 to 8 weeks. If treatment stops too soon, the relapse may occur. Nursing management. The nurse administers antibiotics and intravenous therapies as prescribed and monitors for adverse effects. Chest physiotherapy is initiated as prescribed to facilitate drainage of the abscess. The nurse teaches the patient to perform deep breathing and coughing exercise to help to expand the lungs. To ensure proper nutritional intake, the nurse encourages a diet high in protein and calories. The nurse also offers emotional support because the abscess may take a long time to resolve. Thank you.